All right, let's dive right in. Today, we're going to walk through the official AAU/USUO guidelines for a repeat prostate biopsy. For those situations where the first biopsy doesn't give a clear answer, this is basically the playbook for what to do next. So let's get into it. Okay, so we're going to tackle this in 3 simple parts, following the whole clinical process. First up, we'll talk about what to do with some of those tricky atypical findings. Then we'll get into the huge role that MRI plays now, and to wrap it up, we'll look at the nuts and bolts of how the biopsy is actually done today. Section 1, Atypical Findings, What's Next? This is all about what to do with those specific pathological results. So let's set the scene. You've got a patient, and their biopsy results come back inconclusive. This is where the guidelines really kick in, starting with what to do when the pathologist flags a very specific kind of atypical finding. So the first term we really need to get our heads around is atypical intraductal proliferation, or AIP. Now, what is that exactly? Well, it's not cancer, but, and this is a big but, finding it on a biopsy is a major red flag. It basically tells you there's a much higher chance that a high-grade cancer is hiding somewhere you missed or that one could develop down the road. It's a really crucial piece of the puzzle for figuring out a patient's risk. So if you see AIP on a report, what's the next move? Well, Statement 29 is pretty clear about this. It says that in patients with atypical intraductal proliferation, clinicians should perform additional testing. This is based on expert opinion, and the bottom line is, doing nothing is not the answer here. You've got to dig deeper to really see what's going on. Section 2, the central role of MRI. We're navigating the imaging-guided decision pathway here. So that need for additional testing leads us right here. We know we need to do something, but what? This is where modern imaging, and specifically the prostate MRI, becomes the absolute cornerstone of the whole process. So this brings up a really key question, right? When a patient needs a repeat biopsy, what is the mandatory first step when it comes to imaging? What's the one thing you have to do? And here's the answer loud and clear in Statement 30. For patients who are going to have a repeat biopsy but haven't had a prostate MRI before, clinicians should get one before that biopsy. And listen to this. This is a strong recommendation with grade C evidence. It's a huge deal. The MRI is now considered essential because it gives us a roadmap. It lets us actually see where suspicious areas might be instead of just taking blind samples and hoping for the best. Okay, so you've ordered the MRI. This is where the path splits in 2. So let's take the first scenario. What's the recommended path if that MRI comes back clean, with no suspicious lesion? What do you do then? Well, Statement 31 covers exactly that. If the MRI doesn't show a suspicious lesion, the guidelines say clinicians may proceed with a systematic biopsy. Now, notice the wording may proceed. This is a conditional recommendation with grade B evidence, and here's why. As good as an MRI is, it's not perfect. It can still miss things. So this becomes a discussion with the patient, You weigh their risk factors and decide together if a standard systematic biopsy is still the right call. All right. Now, for the other side of that coin, what's the protocol if the MRI does find a suspicious lesion? How does that change the game plan for the biopsy? This is where Statement 32 comes in, and it lays out a 2-part plan. First, there's the required action. You need to perform targeted biopsies of that suspicious lesion. That's a moderate recommendation, grade C. You have to sample the spot the MRI pointed out. Then there's an optional action. You can also perform a systematic template biopsy. This part is a conditional recommendation, also grade C. So whether you add those extra systematic cores really depends on the whole clinical picture, the patient's risk, how suspicious things look, and so on. Section 3, Executing the Modern Biopsy. This is where we get into the details on technique, technology, and sampling. So we figured out if we're doing a biopsy and what we're aiming for. Now let's talk about the how, the actual nitty-gritty of performing a modern biopsy. Okay, let's talk tech. Statement 33 focuses on something called a fusion biopsy. What is that? Well, it's pretty cool. It's when you use software to basically overlay the detailed MRI map onto the live ultrasound screen you're using to guide the needle. Think of it like a GPS for the biopsy. It's all about making sure you hit that target precisely. The guideline says you may use this, and it's an expert opinion, highlighting its usefulness whenever you have access to it. So you're doing that targeted biopsy. You've found the suspicious lesion. How many samples do you actually need to take? Statement 34 gives us a very specific number. you should get at least 2 needle biopsy cores from each target. This is a moderate recommendation, grade C, and it's all about making sure the pathologist has enough tissue to work with to get the diagnosis right. And last but not least, how do you physically get to the prostate? Semen 35 talks about the 2 main routes. You can choose either a transrectal or transperineal biopsy. This is a conditional recommendation with grade B evidence, which basically means both are considered valid options. The choice often comes down to things like the doctor's comfort with the technique, the patient's anatomy, and importantly, the fact that the transperineal approach can have a lower risk of infection. So let's just recap the big takeaways here. The main theme, really, is that an MRI is now essential before a repeat biopsy. If that MRI shows a suspicious lesion, you've got to perform a targeted biopsy. If the MRI is negative, a systematic biopsy is still on the table. And when you do target a lesion, remember to take at least 2 needle biopsy cores. Finally, the choice between a transrectal or transperineal route is a clinical decision. It's all about a smarter, more precise approach. And that focus on precision really makes you think, doesn't it? Today's guidelines are built around the amazing imaging we have now. So the big question is, as imaging and fusion biopsy tech get even better, how are these guidelines going to change to make cancer detection even more precise? It definitely seems like we're heading towards an even more targeted future in diagnosis. Thanks for joining me.